Hello, I'm Dr. Mohit Kara, professor of urology at Baylor College of Medicine in Houston, Texas. I was also one of the members of the Traverse Trial Steering Committee. I'm very longevity at Harvard Medical School, co-founder of the Androgen Society, and really a pioneer in the field of testosterone therapy. We'd like to welcome you to a practice insight discussion on the Traverse trial. The Traverse trial is the largest randomized placebo-controlled trial ever published on testosterone therapy. The genesis of this trial really started in 2015 when the FDA gave guidance to manufacturers of testosterone products to conduct a well-designed, large, randomized, placebo-controlled trial really to assess cardiovascular safety of testosterone. Due to this unique opportunity, conducting such a trial, the Traverse Steering Committee also incorporated numerous secondary and tertiary endpoints into this trial. These included assessing the impact of testosterone on prostate safety, such as prostate cancer or BPH, looking at sexual function, how to improve anemia and preventing anemia with testosterone therapy, testosterone and depression, testosterone and diabetes, bone fractures, all of which we'd like to share with you today. The Traverse trial had 5,246 hypogonadal men randomized to testosterone therapy, which was androgel, or placebo. The goal was to raise the testosterone levels into the normal range between 350 and 750 nanogram per deciliter. All men had to have either a history of cardiovascular disease or 3 cardiovascular risk factors. The men were treated on an average of 22 months and were followed for an average of 33 months. I'd like to start with a clinical scenario of a hypogonadal patient that many of us may see. EB is a 65-year-old man, recently retired, with a decline in libido, erectile dysfunction, fatigue, and low mood, normal BMI, and managed with type 2 diabetes medications. No history of MI or stroke. His blood pressure is 145 or 95, and he has hypogonadism. His recent testosterone level was 150 nanogram per deciliter, hemoglobin A1C of 7.9, and a hemoglobin of 14.2. He poses a question: I'm worried about my heart. My family doctor mentioned the risk. Is testosterone therapy safe for me? How would you respond? Let's look at the results of the Traverse trial to better understand how we should respond. Again, this trial had 5,246 men randomized to androgel or placebo with pre-existing cardiovascular disease or cardiovascular risk factors. The primary endpoint was incidence to non-fatal MI, non-fatal stroke, or death due to CV causes. The secondary endpoints included incidence of MACE or cardiovascular revascularization procedures such as cardiac percutaneous coronary intervention or CABG. The tertiary endpoints included all-cause mortality, hospitalization, or urgent visits for heart failure or venous thrombotic events. What did they find? Testosterone levels rose 148 nanogram per deciliter in those being treated with testosterone versus 14 nanogram per deciliter in those being treated with placebo. But the key finding was that there was no increase in non-fatal MI, non-fatal stroke, or death due to CV causes in those men being treated with testosterone versus placebo. Thus, I think it's fair to tell this patient that testosterone does not increase the risk of heart attack based on the Traverse results. Next, I'd like to ask Dr. Morgentaler to discuss the insights of the prostate safety from the Traverse trial.
Well, thank you very much, Mo. It's a pleasure to be here with all of you and also to be working with my colleague Mo Kira, who's been one of the great leaders in the field of testosterone deficiency and its treatment, often called hypogonadism and testosterone therapy. Um, so I've been involved with research and clinical work involving testosterone prostate cancer for over 35 years. And this has been one of the biggest concerns, really going back to the 1940s, and the concern being that any increase in testosterone might result in an increase in prostate cancer. Most of the research over the last 20 years has been quite reassuring, but one of the amazing things about the Traverse trial is the size of the trial and also the rigor with which it was designed to look at the prostate cancer issue. So once again, this was over 5,000 men randomized either to placebo gel or to testosterone gel daily, and with a mean follow-up of 33 months. When I say the design was rigorous, what this means specifically here is that Men underwent prostate biopsies according to a pre-specified protocol, and all biopsy results were centrally adjudicated so that there was a consistent way and high-level way of assessing the results of those biopsies. What the results showed was that there were only 5 cases of high-grade prostate cancer in the testosterone group and 3 in the placebo group. Those numbers are almost identical, and both of them are very low. For the total number of prostate cancer cases, again, the numbers are almost identical, with a total of 12 cases in the testosterone group and 11 in the placebo group. On the basis of the TRAVERSE trial, added on to the existing research accumulated over 20 years, I think it's clear now that for a patient like EB, who may have raised, or any other patient who raises concerns about whether or not testosterone therapy may increase their risk of prostate cancer, I think the answer today is a resounding no, it will not increase your risk. I'm going to turn this back now to Dr. Khera to discuss the sexual effects of testosterone therapy.
Thank you, Abe. Another common question I receive from my patients is, will testosterone therapy really make a difference in my sex life? Well, let's look at the results of the TRAVERSE trial to answer this question. In this subset analysis of the TRAVERSE sexual function study, the TRAVERSE trial had 1,161 hypogonadal men randomized to either testosterone therapy or placebo. The primary endpoint was improvements in sexual activity based on the PDQ-4, which stands for the Psychosexual Daily Diary Questionnaire. The secondary endpoints were improvements in hypogonadal symptoms, improvements in sexual desire, and improvements in erectile function based on the HIS-Q questionnaire and the IIEF questionnaire. What did they find? Testosterone therapy significantly improved sexual activity by 0.5 incidents per day or 3.5 incidents per week. And what was interesting is that this was a benefit that was sustained all the way out to 24 months. In addition, testosterone therapy significantly improved hypogonadal symptoms and libido in men compared to placebo. However, testosterone therapy did not improve overall erectile function. Now, this could be due to the fact that this was pre-selected population of men with pre-existing cardiovascular disease or cardiovascular risk factors. I'd like to move on to the depression study of the TRAVERSE trial. In this study, 5,204 men were randomized to testosterone therapy or placebo, and they were divided into 3 groups. 1, all randomized men. The second were all men with significant depression, as defined by the PHQ-9 questionnaire. And third, men who were diagnosed with low-grade persistent depressive disorder, or LGPDD, also known as dysthymia. The goal was to assess not only changes in depressive symptoms, but also changes in energy, sleep, cognition as well, using the HIS-Q questionnaire. These questionnaires were given at 6, 12, and 24 months. What did they find? The results found that those men who were treated for LGPDD, there was no significant improvement in outcome measures. However, 51% of men with low testosterone suffered from some degree of depression. When they received testosterone, there was a modest significant improvement in mood and energy, but not in cognition or sleep. Next, I'd like to ask Dr. Morgentaler to discuss bone fracture data.
Well, thank you, Mo. So let's talk about fractures. One of the surprising findings in one of the sub-studies, if you will, of TRAVERSE was that there was a slight increase in bone fractures seen in the testosterone group compared to the placebo group. Why is this surprising? Well, because we have considerable data leading up to the TRAVERSE trial that indicated that testosterone therapy increases bone mineral density in men and also increases bone strength. And so one would expect that what are often called fragility fractures or fractures that result from low bone density would be reduced in men who would get testosterone therapy. And yet the results of the TRAVERSE study showed there was an increase in fractures. So how do we understand this? Well, in fact, the TRAVERSE fracture study was not designed to look at fragility fractures, but just to look at clinical fractures. Those are fractures where somebody knows that they had a fracture. For example, they fell, maybe playing tennis, and they broke their wrist or something like that. And there was no bone density measurements taken. No DEXA studies were performed before, during, or after the study. And the one of the issues with fragility fractures is that approximately 70% of them are silent. So you may get, for example, fractures of the vertebra, and you can image those, but that wasn't done here. So in this study, 90% of the fractures were traumatic. And the question is, number one, would the study really be expected to find a difference given those circumstances? And one of the variables here, in my mind, is that what testosterone does, and my patients often say this, they give people more energy and more strength and a sense of vitality. And I've had many patients tell me that they've taken up sports that they didn't do before. So since activity isn't measured here, I have to wonder whether it's just increased activity in the testosterone group that may have made them predisposed to falls, which in turn may have increased their fracture risk. Anyway, those are the results. I think it's a little bit of a mess, in my personal opinion, but clearly the study was not designed to look at fragility fractures or fractures due to low bone density, and I think that question remains open. I'm going to turn this back to Mo for a discussion of the effect on diabetes and prediabetes.
Thank you, Abe. I'd really like to finally discuss the results of the diabetes trial. This was a subset analysis looking at 1,175 men with prediabetes and 3,880 men with diabetes. The primary endpoint was assessing if testosterone therapy could cause glycemic remission, in other words, reversing of diabetes, dropping the glucose less than 126 in men with diabetes. They found that the risk of progression to diabetes did to experience glycemic remission or reversal of diabetes placebo group. It's important to note that these findings...
In the TRAVERSE trial looking at anemia, they had 815 men who had a hemoglobin less than 12 and becoming going above normal. We call that erythrocytosis. So it's kind of clever to look at whether or not testosterone might improve unexplained anemia. So in this case, we had 815 men who met the criteria. And at the end of 12 months, the number of men who had corrected their anemia was 45% in the testosterone group and 34% in the placebo group. That was statistically significant and remained so at 24 months. So very interesting, raises the possibility that for physicians who are taking care of men who have unexplained anemia, perhaps there is a reason now to be checking a testosterone level, and if it's low, considering whether or not to correct that testosterone deficiency with testosterone as a treatment for unexplained anemia. Let me now make some concluding comments about the TRAVERSE trial. This was the largest randomized controlled trial ever of testosterone therapy versus placebo. And what we learned from this are several things of great importance to physicians, regardless of specialty. This is really a general medical issue because the things that we are looking at is cardiovascular risk, prostate cancer, sexual function, anemia, bone, diabetes. This is all of these topics are of great importance. And what TRAVERSE showed us is that testosterone therapy has very important effects in terms of benefits, in terms of sexual activity and libido. It showed improvement in anemia. And it showed, I think, conclusively that there was no increased cardiovascular risk and no increased prostate cancer risk. Those results by themselves are terribly important for anyone who is interested in this field or who takes care of patients who may be testosterone deficient. I think TRAVERSE will go down as one of the great landmark studies in medicine in general, and certainly in the field of testosterone deficiency or hypogonadism. It's been a pleasure being with you all, and I thank you for your attention.